Hey there, welcome everyone to the EMS Academy. For those who I haven't met, my name is Sean Barinholtz. I am an anesthesia and ICU physician at Hopkins. I am an active member of Pikesville Volunteer Fire Company and have the honor of serving as one of the assistant medical directors for Baltimore County Fire Department. On behalf of Dr. Jeff Nusbaum and the medical director's office, Chief Nats, EMS office, EMS Training Academy staff, and Captain Lenny Stewart, thank you for what you guys do every day to help our community, and thank you for your dedication to lifelong learning. Big shout out to Ashley Brooks, a young volunteer at Pikesville, who's helping us run the Zoom platform. Ashley's also the one who will put a link in the chat later in the training. Click on the link, fill out some information, get your MIM CEUs. If you have any questions about past participation in MIM CEUs, have trouble signing in, or have questions about your record of attendance, please hang out with us after the training, and we'd be happy to help you and answer your questions to make sure that you get your MIM CEUs. So tonight couldn't be any more excited to have with us Dr. Nusbaum. He's began his emergency career as a volunteer firefighter with the Bryn Mawr Fire Company in Bryn Mawr, Pennsylvania, while attending Haverford College. He subsequently attended Georgetown University School of Medicine, completed a residency in emergency medicine at Mount Sinai Hospital in New York City, fellowship in emergency medical services at the University of Pittsburgh Medical Center, and MBA at the Katz School of Business in Pittsburgh. He served as medical director for several ground EMS agencies throughout Western Pennsylvania and flew as a flight physician for STAT MedEVac. In 2021, he joined the faculty at the University of Maryland as an assistant professor working clinically in the emergency department. He continues to spend most of his time with local emergency responders, serving as the medical director for Baltimore County Fire Department, assistant medical director for Baltimore City Fire Department, and assistant medical director for the University of Maryland ExpressCare Critical Care Transport Service. Dr. Nusbaum, welcome, and thank you for all that you do. We appreciate you.
All right, thanks for having me, Dr. Barinholtz, and thank you everybody for coming on this incredibly dreary and incredibly foggy night. If the radio is indicative of anything, it would indicate that you should not drive tonight, because every citizen of Baltimore County has had a car accident tonight, so please don't be one of them in the future. So I am going to be talking tonight about the SADS epidemic. That is an epidemic that's been plaguing plaguing society for decades, was only recently recognized and is now starting to be studied. I'll apologize in advance because I have about 13 different URIs from my 3 young children, so I won't be dying during this, but I will be coughing. You're not supposed to talk about yourself during presentations, but I haven't had the pleasure of meeting many of you, so this is the less than 2-minute overview of my life. I'm from New York City, Jets, Yankees fan, a little bit of bizarre combo. I've spent time in almost every major city on the East Coast, plus Pittsburgh. As Dr. Barinholtz mentioned, I went to Haverford, where I was a volunteer firefighter. Came back to New York, where I did some volunteer EMS. DC at Georgetown, back to New York. Pittsburgh for 3 years. I was planning to hate Pittsburgh. I actually loved it. I didn't love the Steelers, but I loved the city of Pittsburgh. Was really kind to me. And I came back to Maryland to be close to my in-laws, to take care of my 3 kids, to help take care of my 3 kids, because my wife and I are quite busy and we just needed some help. Pittsburgh is an interesting place to train as an emergency physician. Pittsburgh owns, now they're up to 46 hospitals, UPMC is. So they have 46 hospitals spread across all of Western Pennsylvania, now the middle of Pennsylvania. and they do a robust network of EMS medical direction. Something like 60 to 70 EMS agencies call into Pittsburgh for EMS advice. They also have an app where you can literally summon a helicopter from one click of a button on your phone. It's just a different way to practice medicine. That's the picture of my phone the other day. I had great battery power at the time, as you can see, and I could have called a helicopter. If you press the button, someone will call you and say, "It looks like you're here. You really need a helicopter?" Okay. We did a lot of medical direction. That's Dr. TJ Doyle. That is not, in fact, me. He was the medical director of the UPMC Medic Command. So there we did EMS medical direction for all these fire departments. And it's interesting because we didn't use destination command for the most part in Pittsburgh. You called a doctor in that office where Dr. Doyle is. So for 8 hours, all you did was EMS consults. And it was great because you didn't have to focus on patients in the ER. UPMC actually funded this position to help our EMS clinicians get good attention. Instead of now, I'm an emergency physician, hand up, you call me, I'm doing 13 things. There's just no way I can give you my full attention. But I sat at this desk with a communication specialists helping me out, or multiple of them. And we did a great job, and we got to know our providers. I was the medical director for a number of different fire departments, EMS agencies. No real true county EMS, but Washington County was served by one agency, so almost county EMS. So I've done a lot in the medical direction business, and it's what I enjoy the most about being an emergency physician. Quick aside, we also did online medical control for a bunch of airlines. You may have heard of some of these or flown on some of these yourself. The only story I'll tell you is once I was dealing with an LVO on an Emirates flight, and they asked me to call the Iranian military to ask not to shoot if they went into the airspace. A guy named Nusbaum calling Iran is really the beginning of a very challenging and sad story potentially, but it ended well. The guy got care pretty quickly. So that's my old picture of my old hospital, my last shift. Someone actually posted on Facebook, "Is anyone missing this horse? He's now in the parking lot." So I went from horses in the parking lot in rural Pennsylvania over to University of Maryland. I work primarily at the Midtown campus. I spend most of my time with the county fire department, a little bit with the city fire department, a little bit as an emergency physician, and even less with ExpressCare. Great clinicians, great experiences all around. I just wish there were about 48 hours in the day. I'd be a lot more productive and have a lot more fun. Every presentation has to talk about some objectives. There they are. We're going to talk about the critically unstable patient protocol. We're going to discuss some of the literature. We're going to talk about a little bit into other areas where this matters as well. And then I was going to talk about cases of SADS out there, but we're not going to do so much of that. Feel free to interrupt at any point. I might actually appreciate it so I can get a drink of water or seltzer. I have a seltzer bottle that'll blend in nicely with the background. So that's great. Dr. Barinholtz will monitor the chat and interrupt me as needed. I'm not offended. I also am from New York City, so I talk very quickly. If you're having trouble understanding me, by all means, ask me to slow down and I'll do it. So the inspiration for this whole talk is actually the story of the Freedom House paramedics. If you haven't heard of them, I encourage you to either Google them or read this book, American Sirens. So in the middle picture there, you can see this guy, Peter Safar. He's known as the father of CPR, the father of ICU, ICU medicine. He really invented the ICU. He actually was in Baltimore very briefly, but then moved out to the University of Pittsburgh. His daughter was 12 and she died of asthma, and she died because she didn't get care fast enough. Also, there was a very high profile death in Pittsburgh where the governor got on-scene CPR in a theater, or the lieutenant governor got on-scene CPR in a theater, and then in the 1950s, 1960s, the police come and take you to the hospital, but they don't care for you. And so this guy who got immediate on-scene CPR by an ER nurse, or a nurse who worked in the same ER where he worked, the guy died of an anoxic brain injury. And he said, "This is just crazy. We have to start this thing called street medicine." And so he basically invented paramedics. He took these, and these are not my words, these are his words, these unemployable Black men in Pittsburgh, and he created a paramedic program. The woman on the left is Nancy Caroline. She is credited with essentially writing the first NREMT curriculum. She invented the idea of an EMT. And so Caroline and Safar took these paramedics into the hospital, they trained them, and they taught them how to perform medicine. And it is just an amazing story that's completely forgotten. So the book's good. I actually going to work with Dr. Barinholtz to see if his name is on the right there, Chief John Moon. He's one of the surviving original members, to tell the story because it's pretty compelling. But I was reading the book again a couple weeks ago, and I was struck by this quote that Dr. Safar, like 1965, went to Germany, and he said, "There is no evidence of reduced mortality and morbidity with advanced life support rendered by physicians riding ambulances versus well-trained paramedics." So he basically invented the paramedic and then told a hospital, like, you know, "Hold my beer, we're going to do this better than you." And this guy was bold, and what he did was really amazing. So if you remember nothing else from my presentation, is like, this is your space. You are the experts in this space. Out of hospital resuscitation, acute resuscitation, this is for EMS. This is for you. The imperative to get to the hospital does not exist. So we'll start with a case. This is not actually Medic 56, but I found a nice picture of an ambulance that would go next to it. And I'm going to read the slide to you. She, being an aide, found the patient like this, and she had vomited several times, so she, the aide, administered her insulin. The patient was transferred to the stretcher and placed on a 3-lead, where she was noted to be bradycardic. At this point, the crew rapidly moved her to the medic. 2 IVs were placed, an 18 in the right wrist, a 20 gauge in the left forearm. LR was administered by a pressure bag, and pads were applied for pacing. While setting the pacer, electrical capture was noted. However, no mechanical capture was palpated, and the patient is now apneic. The case goes on. The patient ends up in cardiac arrest. They continue working the arrest. They get ROSC. ... Now, this stuff happens all the time. You've all been on this call where you're like, oh crap, and I apologize, I curse a lot. I'm going to try to do less of it because it's recorded, but it's like, oh shit, like this person is sick. This person is sick. We got to get to the medic and then we'll get going. Like once we get downstairs, I don't want to deal with wires. You know, we've been there. I've been there with you. I mean, believe me, I do this more often than I'd like to admit when I ride along with people. The patient's sick. What do? We got to get to the medic. Like your brain is just telling you, you must get outside to the medic. And that's what we're going to talk about today. So this patient is apneic as soon as we arrived in the medic. They weren't apneic before. If you look at the care they provided, it's actually fantastic. 2 IVs, an 18 gauge in the wrist, and an elderly woman. I mean, that's not easy. Pressure bagging fluids, pacing people, quick EKG. I mean, this is actually, the care that was provided was great. It just was a little bit at the wrong time here. So what actually happened in this case? You know, should we have hired faster paramedics? You know, would Lamar Jackson be the better person here? Because we just need to get him down to the medic faster. You know, was this lady just too sick? Was she going to die regardless of what we did? And we just captured her at the wrong time in her disease course. You know, maybe Baltimore County has toxic medic units. I don't know. Like maybe there was some gas that was in the medic and she just died. And that's not the case. And this is where if I had a narrator with where they would say like SADS has entered the chat. And SADS, sudden ambulance death syndrome. That's what this lady died from. She died from sudden ambulance death syndrome. This is a picture from this guy named Daniel's son. He's a paramedic in Canada, and he has very emotional EMS photography or EMS portraits that he puts up. So I encourage you to Google him. So SADS, this is a case of SADS. So what is sudden ambulance death syndrome? I hope he doesn't watch this, and I don't know if this is an accurate statement, so I'll caveat this. But I think Dr. Veervith Naldi coined this term sometime in 2018. People were talking about it around 2018, 2019, but he's the first one I ever heard say the word SADS. And if I were talking about SADS, I would always say SADS because that is a great phrase, and it accurately describes exactly what we're talking about here. So what is SADS? It's a poorly defined condition when pre-hospital clinicians find a patient alive and doing well, but upon promptly moving them to the medic and begin resuscitation, the patient arrests almost immediately upon arrival to the medic as if the medic itself is the problem. Definitely not a term you can find codified anywhere in the literature or in Comar in Maryland, but everyone knows it when you talk about it. The incidence is completely unknown, but every system has quite a bit of SADS. And again, I think Dr. Vithalani is the one who coined this term. So what is SADS pathophysiologically? I am speculating here because no one has studied exactly what it is. And it's probably like everything, not black and white, and some combination of all of these things. So probably what's happening is when you get called to an incredibly sick person, that person has put themselves in a position where they can compensate. Maybe they're tripoding, maybe they've prone themselves, maybe they're sitting on the side and their lung is in such a way that they're aerating the good lung, but they've naturally found themselves in some position where from a respiratory standpoint, they can compensate. And when we do our job, which involves necessarily moving them, because we have not invented the teleportation protocol yet, we take away their compensation. We strap them to a stair chair, we strap them to a Reeves, we lay them flat. You know, maybe we compromise all the compensation they've already had. Or maybe it's a little bit like crush syndrome, where the person's just laying down, you know, their legs are maybe dangling off a bed, or maybe they're sitting in a chair, and all this ischemic peripheral tissue has lactic acid building up. Maybe some cells are lysing because it's so acidotic and they're so poorly perfused. So you get potassium and phosphorus leaking out, sort of like crush syndrome. And so maybe when we pick them up and lay them flat, maybe all those evil humors come back to their heart and cardiac arrest ensues. Potentially, it's the adrenaline surge. You know, they've managed to stay alive just till this exact last minute, and then at the last minute they get this final adrenaline surge, and their heart just can't handle this big bump of epinephrine, or maybe they're just out of epinephrine and they give it their last shot. It's probably, again, some combination of all of these things, but it's not really known. So I'm telling you these things and I'm asking you to trust me. You have exactly 0 reasons why you should trust me besides the fact that I applied for a job and got it, but that's not enough reason to trust me. So is there any data to talk about SADS? So some of the first data comes from Pittsburgh EMS, and it's always important when you look at EMS, when you look at data, to understand the background. So Pittsburgh EMS is very different from basically everywhere in the United States. Pittsburgh EMS is third service EMS. So there's a police department, a fire department, and an EMS department. They all have their own chiefs who report to the mayor. In Pittsburgh, you got 2 medics on every truck, with the exception of the BLS units, which are a fairly new inception. All rescue in Pennsylvania is carried out by paramedic divers on boats, paramedics who rappel down from the aerial ladder by the fire department, paramedics who cut cars. So it's a very different system. You also have a physician. That's my old car that I was trying to hide behind a tree. It's hard to hide an orange striped car. And they have physicians on the road 24/7, 365, mostly to help with high risk refusals. So that's Pittsburgh EMS in a nutshell as an overview. So what did Pittsburgh EMS do and study? So sometime 2014, 2015, they said, we got to stop having people die. Let's invent this crashing patient protocol. So the crashing patient protocol was basically don't move the patient, monitor the patient, manage the airway, IV access, IV fluids, push dose epi, and then maximal medical therapy prior to movement. Do not move the patient until you can actually assure them that they're going to make it to the ambulance. So Pittsburgh EMS runs about 90,000 calls a year, 80 to 90,000 calls a year, somewhere in the 40 to 60,000 transports a year. So half-ish of Baltimore County and Baltimore City transports. It's somewhere in that range-ish. And it took a while to get enough data. So what did they find? They presented this, Mark Pinchuk, who's now the assistant chief of EMS in Pittsburgh, presented this data January 2019 at NAMSP. He swears to me he's going to write it up. I told him he has to. It's just too important. So before the crashing patient bundle was put into place, Pittsburgh EMS had a 12.1% post-contact out-of-hospital cardiac arrest rate. So anyone with these concerning vital signs, they had a 12.1% chance of dying. After they put in the crashing patient bundle, immediately they dropped the post-contact out-of-hospital cardiac arrest rate down to almost 6%. They cut it in half. And if you say like, oh, but some people are just going to die, they looked at it again, looking at just the patients who arrested after 5 minutes after contact, saying, you know what, some people, you just don't have time to save them all. That some person is truly going to die right as you get there. Let's exclude them. And still, if you exclude those patients, the data stands up about half. You cut the incidence of cardiac arrest in half. Now, that's not survival. That's not mortality. Obviously, if someone's having a cardiac arrest, their mortality is going to be high. Survival's likely going to be poor. But they cut it in half. And that's profound. I mean, that's profound. We're talking about cutting cardiac arrest in half. Their data was so compelling that the then state medical director, with the help of now assistant chief Mark Pinchuk, had it put into the Pennsylvania crashing patient protocol, which is for those of you that work or volunteer in Pennsylvania or live in Pennsylvania, it's protocol 3000A. So what did the crashing patient protocol say? It's not changed very much, so you can reference the current manual, but step 1, bold, underline, do not move the patient. Consider calling for backup, apply your standard monitors. Step 1, if in terms of care, is really manage the respiratory problems first. CPAP, NEBS, high flow oxygen, whatever you can get. Do not move to the next step until you've maximally managed their respiratory status. In the ABC algorithm, once you've taken care of AB, you move to C. So then you assess circulatory status. You look for people who are hypotensive or any dysrhythmia. Immediately obtain IVIO access and start giving fluids or either push dose epinephrine. Pennsylvania loves push dose pressors, Maryland not so much. So again, respiratory first, cardiac second. The crashing patient SADS data literature, it kind of fell silent for a number of years. I couldn't find really that much between 2019 until 2021. I don't know if something big happened in 2020 that distracted everybody from looking into SADS syndrome, but no one really talked about it for a while. Then in 2021, again at NAEMSP, the National Association of EMS Physicians Conference, Buffalo presented their data. So they said that about 10% of the arrests they witnessed were after arrival. 10% of the cardiac arrests they encountered were after arrival. They didn't call it SADS or crashing patient. They called it PARCA, post-arrival respiratory and cardiac arrest. I guess it's catchy, but nowhere near SADS. They had a 12% survival of those that they witnessed arrest. And they found that the people that were surviving were the people who got care earlier. It's not terribly surprising, but the people in that group that survived were the people that they initiated therapies, but way before they actually crashed. Additionally, when they looked at it, the most common intervention that everyone got just prior to arresting was moving. Moving the patient was the most common intervention. Same conference, MedStar Texas, Dr. Vithilani's group presented some data similarly. They talked about just some overarching themes. So 50% of the SADS cases were respiratory, 25 were cardiac, and 25 were other. I suspect that means they just couldn't figure out what was happening. Maybe they attributed it to like sepsis or something like that. You don't have to memorize all these numbers. The theme is that people are crashing from a respiratory standpoint. Almost nobody had a SAT above 90, 84%, 83% had a SAT below 90. 10% had readings above 90 immediately prior to movement, which means 90% were hypoxic. 30% should have been ventilated and they weren't. So what Dr. Vithilani's group, the MedStar group in Fort Worth, Texas, what they concluded is that SADS is both predictable and preventable, which is such an important thing. Predicting something is one thing. If you can't do anything about it, it's useless. It's like not knowing they're going to crash is one thing, but being able to address it is a whole other thing. So Battalion Chief Tim Burns in Montgomery County, who may or may not be on this call, Battalion Chief Burns and Medical Director Roger Stone in Montgomery County in July of 2021 saw the Maryland version of the crashing patient protocol, thanks to their advocacy, come to fruition when it made its way into the Maryland medical protocols. For now, and I think next year too, it'll be at the base of the general patient care protocol. It's the last part of it, the critically unstable patient protocol. It's section 2.4. Pennsylvania is a lot more proscriptive than Maryland. It's just the way they do EMS. The protocols tell you exactly what you to do step by step. Maryland's a little bit broader, leaves a little bit more up to clinician judgment here, but more or less these protocols are the same. So who does the crashing patient bundle or the critically unstable patient protocol, who does that apply to? Anyone who's newly altered. Now, you might say, well, they're all on drugs or they're all old people in nursing homes. Doesn't matter. They're newly altered, so this technically applies to them. Anyone with airway compromise, anyone with respiratory distress, anyone with poor perfusion, cap refill, cold extremities, or your paramedics. You're very well trained. Your EMTs, you know when someone is just not well. So if you think they're at risk for decompensation, you should enter into this pathway. What do you do? Step one, same as Pennsylvania, cease all efforts at patient movement until treatments in this protocol are complete. And that's important. It's not do a little bit of it. It's do this whole protocol. And this is the protocol. I mean, technically it's a violation to run to the ambulance with someone who's hypoxic. We'll get into if it's always a violation or not, but you have to consider that. So what do? Cease patient movement, get your vital signs, including pulse oximetry. Obviously, vital signs include pulse oximetry, but there is an extreme emphasis on this because of the data out of Texas and because of the data out of Buffalo. If there's any bleeding, non-traumatic bleeding or traumatic bleeding, control it. You know, this protocol isn't meant for trauma patients, though the themes do apply. Manage the patient's airway with ventilations, treat hypoxia. Almost all the BLS clinicians in Baltimore County are able to do 12 leads and obtain vascular access and start IV fluids, so we can move 2 and 3 up to the BLS as well. And then once the ALS clinician gets there, end-tidal CO2 monitoring, so important. More fluids, vasopressors as indicated, address any life threats, and then perform your regular medicine. So you can see here this group of clinicians on the left side, they've performed the crashing prediction protocol so well that this gentleman is now giving them the thumbs up. He went from crashing to AMA or refusal of transport. So that's great. So my goal is always to be transparent and be forthcoming with you all and never lie to you. But I've sort of lied to you. I've sold you that this is great, that the literature is great, and that everything is fine and we need to trust it. And that's true. But I didn't tell you how many patients were in these studies. And that's because when I started this endeavor, after Dr. Barinholtz and I talked about this presentation, I said to myself, there's tons of literature out there. This is going to be easy, but there's just not. And then when I read the literature, the stuff that I just showed you, I was appalled. Pittsburgh EMS, I didn't even realize this. We published that abstract on, less than 500 total patients. I was like, holy cow, this is a small group. MedStar's abstract was based on 30 patients. Buffalo, the data from Buffalo that I showed you, that was based off of 2 months of data. And I mean, the trend is very clear. But this is crazy. I was frantic. I almost had to email Dr. Barinholtz and say, we can't do this presentation. I don't have enough data. I'm talking about some voodoo that medical directors are spewing out there. I'm sure it's true, but it's not really science. And that concerned me. The title of my presentation that I emailed him, I said it's an epidemic. And now I can barely find 1,000 patients that have been studied. I mean, CHATS is an epidemic. This is chats from early January. Every hospital being on red and yellow. Like, that's data. Look at that. That's a problem. But SADS, there's no data. It's not really an epidemic. Thank God I went to this conference, NAMSP again, in January, and I came across the exact poster I've been looking for the last 3 months. So this is a poster out of ECU, East Carolina University, and Andrew Bouland was actually a medical student at University of Maryland, but he's now down there as an EMS physician. And he created the exact poster I've been looking for: preventing SADS, analysis of initial vital signs, and time to first treatment. So what did the ECU group do besides have one of the most badass EMS patches I've seen in a long time? So the ECU group used the ESO data set. So ESO is an EMR, is a widely used EMR around the country. They provide EMR services to EMS, fire, some hospitals. They're in a lot of different spaces. Tons of people put data into their EMR. They came up with their own criteria for crashing patients: an SpO2 of less than 90, a MAP of less than 60, bradypnea, tachypnea, bradycardia, tachycardia. And those cutoffs are going to be pretty close to things we can all agree on. And you got to agree on something if you're going to do research. They excluded all the typical people we exclude: kids, trauma, pregnancy, anyone who's already dead. They chose to exclude people that died within 2 minutes, saying, honestly, like, what can we expect someone to do in 2 minutes? It's just not fair. And then they looked at the time to first treatment. They defined first treatment as pacing, cardioversion, IVIO access, epi administration, O2 administration, non-invasive ventilation, NEBS, supraglottic airways, or endotracheal intubation. The only thing I wish they included here would be to look at Narcan, though technically by the book, all of the people that need Narcan are probably hypoxic and should be getting oxygen. And so they probably are caught and included via other means. But I would have been interested if intranasal medications could have been included as well. So what did the ECU group find? They looked at 7.6 million patient encounters. I just told you about Pittsburgh EMS and our 300 encounters. They looked at 7.6 million patient encounters and included almost 200,000 patients in this data. That is ridiculous. Of those 200,000 patients, about 5,000 of them had a witnessed arrest. And here is the second thing you must remember. They found that each minute delay, and that's again a delay to a first therapy, any first therapy, was associated with a 4.4% increase in your risk of sudden ambulance death syndrome. That is crazy. So we will say it again. We will put it on a big slide. I will take a breath and pause so the people that are only half listening. Now you've listened a little bit. Now you checked your audio. It still works. That was me pausing so you can all read this slide, which is in very big font. Each minute delay to the first intervention was associated with a 4.4% increase in your risk of dying, of having a cardiac arrest. That is bonkers. They broke it down further by abnormal vitals. So I don't know if my cursor shows up on your screen, but in figure 1, you can see percent survival as compared to first time to first treatment. You can see that at minute 2, everyone's alive because they excluded anyone that arrested it before 2 minutes. By 10 minutes or so, you're already down to about 40, we'll call it 38% survival. Same thing with respiratory rate. The curves may be a little bit flatter, low heart rate. The curves look all the same, and the theme is about the same. You have a precipitous decline in survival, death. I'm not talking about like sort of bad things happening to you. I'm talking about actual dying. And you cut that in half if you intervene earlier. Figure 4 is a combined survival curve. Again, this is where the 4.4% comes from, but these figures should be burned into your head now. This is so important that critical SpO2 less than 90. We see people with SpO2s less than 90 all the time. I mean, these are routine patients for us, and if we don't intervene on them, they're going to die. And statistically, they're going to do worse. Now, you might be saying to me, like, come on, we can get to the medic pretty fast. I've seen it. This department works very well, Our suppression colleagues, if they're not there providing care, they will get these people in a Reeves and get them to your medic very quickly. I bet if you challenged Engine 1 or whoever you're with tonight, and you said how quickly you get them out, you'll see 4 men and women run, and that patient will be in the ambulance pretty damn fast. But honestly, let's think about it. If you get there, let's say you do the quickest assessment, like a rapid focused assessment. I'll give you 30 seconds. You can undress them however you want to undress them. Lay your hands on a bilateral radial pulse. Ask them two or three questions to figure out how sick they are. I'll give you a minute. I'll presume you brought the stair chair or the Reeves with you to begin with, and I'll give you a minute to safely get them in there and strap them down and decide how you're going to carry them. We'll say it's the most easy to get to scene to medic. The doors are all wide. There's not that many steps. And I'll give you a minute to legitimately pick them up and get them outside. I'll give you 30 seconds to transfer them to the stretcher, and then another minute once you're inside to gather vitals. And I'd say that's fairly conservative. And that's 4 minutes. That's 4 minutes. And I was pretty good. Maybe you say, oh, you're still too slow. You're not going to cut that down 50%. Maybe you cut it down to 3.5. You're still talking about a 10% risk of SADS, of sudden ambulance death syndrome, and that's if your crew is hauling ass and you're on your game. So just think about the typical extrication, which involves the tightest stairway in Dundalk with 14 couches you have to step over, 7 family members yelling, 14 steps with crooked concrete on the way out, and then no one who even has met the patient before in your life, or you're 75 rooms back in a nursing home, the patient just got there, it's everyone's first day at work, and you've been handed a packet of 400 pieces of paper, and you got to use an elevator to get down. I mean, it takes a while to get to the ambulance, whatever we think. So, but we have a protocol in Maryland, you guys are great at following protocols. You guys don't want to kill people. Why does this keep happening? And that's because the reality of the situation is that EMS is hard. This is a hard job. I mean, a couple of years ago, I think 3 years ago or so, there was a trend of people taking pictures with all their equipment. I mean, this is crazy. EMS equipment is heavy. You have a lot of equipment. It's just insane if you think about how much stuff you carry. Ambulances also feel safe. For the career members of this department, you probably sit in that ambulance more than you sit in the station. And that, in a way, is your safe space. Some of you, unfortunately, may spend more time in your medic than you do in your house. I mean, there's a reason you like this place. There's good lighting. All your tools are there. Presumably, the ambulance doesn't smell terrible. There's no hoarding conditions. Maybe there's no drugs or open alcohol around where you're trying to work. There's space. You're proximate to the other members of your team who can all fit around you. There's a seat called the airway seat. It's built for this. There's another problem. Typically, traditionally, decades ago, we taught you there were 2 things: stay and play or load and go. Oh, they're sick, load and go. They're sick, you got to get out. Sick, load and go. And we taught this as if there was a dichotomy. You were either not sick, stay and play, or you were super sick, load and go. And there was nothing between. We typically, early 80s, 90s, maybe early 2000s, load and go, stay and play. It's a dichotomy. There's nothing in between. Then we have all these pathologies. Time is brain, time is heart, time is whatever. They're not wrong, but that teaches you that time is everything, and you're getting pressured constantly to get the fuck out and get to the hospital. And it's hard to forget that that doesn't matter every time. And then lastly is the public. You know, there's a humongous misconception about what you all do, what we do, what I do. You know, the idea that you're an ambulance driver. You're like, why are you even providing care? You're an ambulance driver. Drive me to the hospital. I called the red Uber that I reached by calling 911. The public has no idea what we do. Then I'm telling you to work the patient in the house. It's like, Mima over there is sick. You got to get the fuck out of here. Like, why are you messing around with my grandma? You're going to kill her. It's hard to battle that perception. This is the cell phone era. I just left a call with Engine 19 where there were 4 vehicle MVC. There's like 120 people looking at us. They all have cell phones out. You're being watched constantly. And then there's the media and the TV and all this stuff in general. Everyone knows about the hero firefighter running around with the sick person, running them to the ambulance. We all know that that's the hero. So the public thinks that running people to the ambulance quickly makes you the hero. No one is saying paramedics brought their equipment inside. They're the hero inside. No, I'm not saying you shouldn't run someone out of a fire. I'm not advocating that you resuscitate someone with active fire around you. I'm just saying that we've all been taught from a very young age. My 2-year-old knows that heroes run people out of burning buildings and run people to ambulances. We've just been trained that that's what we do. I am here to remind you, if you don't already know, or tell you or remind you if you don't already know, that this is not in your wheelhouse. This is your wheelhouse. EMS is here for hyperacute resuscitations. Dr. Saffer and these Freedom House paramedics, the first paramedics in this country, they knew this from the beginning. This is a skill, and it's the skill that you have. And there's a reason when we call 911, we call you and don't call the police with a car to throw them in the back anymore. That's because this is what you do. What you do matters, and when you do it well, people live, and that's why you're here, and that's why you should come to work every day. Now, I would like to think I am incredibly realistic with all of this and understand that things are fucked up. Like, I get it. I really do get it, that I am telling you to follow a protocol. If you follow the protocol, things will go well. But I understand, and I don't want to put words in his mouth, but Dr. Chismar also understands that things are not black and white, and that can't happen every time. We have several realities, especially in Baltimore County. A medic up in the northern end of the county, above Chestnut Ridge, a medic up by 60, the job of that paramedic and the amount of things they do will be very different than the medic in Towson, who has 2 hospitals almost within their line of sight. I'm not discrediting the medic in Towson. I'm just telling you, reminding you that I get it. What happens at 60 is going to be different than what happens at 1. We have BLS clinicians. We had about 10 AMBOs on the road today in the career side of things, and several on the volunteer side as well. I get it. ALS backup, be it a medic unit or a supervisor, may not be there very fast. Sometimes you're on Franklin Square Drive and you can see Franklin Square Hospital. I'm not suggesting that you sit there and wait for an ALS provider to put the patient on CPAP before you move them to your ambulance to drive them 50 yards to the hospital. I'm not suggesting that at all. I'm just suggesting that we have data and I understand the problems we have. I also understand that working someone where you find them is not always ideal. If you have a cardiac arrest on that couch, I don't know that that couch is the best place to resuscitate you. I don't know that you can put 4 firefighters, two EMS clinicians, and an EMS supervisor, and if I'm blessed enough to be there, a doctor as well in the room. I don't even know if we fit there. I don't even know if it's safe to be there. I also don't know that if you find someone in arrest on the side of the road, like we did yesterday, Chris Broussard had someone who walked out of his car, had an arrest, and was on the side of the road. I don't know that it's safe to be resuscitating someone on the side of 695. It's frankly dangerous for you, and that's probably not worth it. So I get it. I get it. I understand that everything is not perfect, but what I need everyone to think about, and what I ask that for those of you that work with me or work in neighboring jurisdictions or work anywhere in the country, is that you think about this balance. So there is a 4.4% decrease per minute in chance of actually dying if you move the patient. You're balancing all these other things: your safety, the ability of your team to work, the ability of you to get back up, the distance to the hospital, with this 4.4% chance per minute, and it's a balance. So all I ask is that you consider moving the patient to be a medical intervention. If you think your safety is number one, 100% of the time. Your safety number one, your team safety number two, you going home to yourself, your wife, your kids, your pets, whatever, that is the most important thing you do. But if you think you can do justice to the resuscitation by not moving them, you need to think very damn hard before you move that patient. You need to think really, really hard, because I have 7.6 million patient encounters with 200,000 crashing patients to suggest that we have good data that if you move them, their chance of dying will increase. Treatment in place matters, not just for the people that are about to die. It matters for other people as well. This is a picture of one of our rescue task forces in Pittsburgh. When I was a fellow, the Tree of Life happened. You can see police officers, paramedics, we all had vests for better or worse. And this was them running in to get the officer who had been shot. He was shot in all four extremities. He came out of the house with six tourniquets, out of the synagogue with six tourniquets on. He was treated by two Thames paramedics in the synagogue about 6 feet from where he was shot. He had all the tourniquets on. He was extricated to a warm zone where further care was given, extricated to an ambulance where the remainder of the crashing patient protocol was completed, including a dose of ketamine. So he hopefully didn't remember this horrible day of his life, and he survived and is trying to be back on the force. He may actually be back on the force. So treating people in place matters. This is the same with cardiac arrest. And I know you all know this because we drilled it into you, but there's huge, huge, huge data sets to support treatment in place. So this is a small journal called JAMA. You may have heard of it, one of the main medical journals out there. They looked at over 40,000 out of hospital cardiac arrest. So the survival to hospital discharge, 3% when you had intra-arrest transport versus 12% survival, not death. So 12% survival when you had on-scene resus. If you match the people, so you found a 60-year-old who got resuscitation in place versus a 60-year-old who got resuscitation in transport, you still doubled survival if you resuscitated them in place. And it's not just survival, it's neurologically intact survival. So neurologically favorable outcome only 3% of the time with intra-arrest transport versus 7% on scene. The same is true for kids, which is not terribly surprising because a lot of the pediatric literature is similar to the adult literature, though on a slight delay. Turns out in this sense, kids may actually just be small adults for resuscitation purposes here. This data showed that if your scene time is less than 10 minutes, that kids had a 5.3% chance of survival. But if you stayed on scene from 10 to 35 minutes, your survival doubled by staying more than 10 minutes to 10%. I mean, I'm not talking about, morbidity and mortality. I'm not talking about little things. I'm talking about a child lives. Twice the number of children will live if you spend at least 10 minutes on scene. Surprisingly, if you spend more than 35 minutes, survival is as high as 7%, which is really crazy because the longer you're on scene, the chance of dying has to be more, just because eventually you're going to die. Like, you just can't do CPR in place forever. But even if you're on scene for greater than 35 minutes, your survival's still better. You're still better off than just running away from the scene. It's interesting, this isn't exactly treatment in place, but this other study, I wanted to get away from acute resuscitations, but really focus on why what you do matters. This is a study looking at asthmatics. And so you might say to yourself, like, look at this, steroids. Like, steroids don't take effect in minutes. They take effect in hours. Typically, our EMS interventions, we don't even have the patient for hours, though. Lord only knows, tonight we're probably going to offload for 2.5 hours at a hospital. You may actually watch the patient for up to 2 hours, but the steroids don't even take effect while we're caring for the patient. But if we're diligent and give that asthmatic who warrants steroids a dose of steroids, they have a shorter emergency department length of stay. They have a decreased hospitalization rate, and they have a decreased need for critical care. I mean, that's in asthmatic kids, but this is another really large study that's well done. And this is why you do what you do, because it matters. Even if the treatment doesn't take effect in your time with them, it makes a difference. So I thought I was going to take an hour, but I've talked incredibly quickly. Slow down. Consider patient movement as a procedure, like you were going into eMeds and clicking the box. What did you do? What procedure did you do next? We extricated the patient. That is a medical procedure because you were doing it to delay other procedures. Moving an under-resuscitated patient is harmful. If a patient meets the crashing patient protocol, depending on whose you use, but if you use the ESO cutoffs, bradypnea, tachypnea, tachycardia, bradycardia, low MAP, low SpO2, if you move a patient and have not started your resuscitation, every minute it takes you to get to the ambulance, you have a 4.4% chance of causing them to arrest when they get to your ambulance. With all of that said, what you do is incredibly hard. You don't have nearly enough time to do all the things we ask you to do. We have tons of equipment we ask you to be experts on using and move around. We put you in really shitty situations, which are sometimes harmful to your own life. We have taught the public. We used to teach you to run to the hospital. We've taught the public to shoo you out the door and to disrespect you by calling you ambulance drivers when you are oh so much more. I get it. There's pressures everywhere, but you need to do the best you can do for that patient and know you're doing it. When you decide to move the patient, because there's lots of reasons to move people, the house was too small, we didn't fit, the ALS provider was a million miles away, you were actually in the lobby of St. Joe's and they inappropriately called 911, just document why you did it, and that's fine. And remember, foremost of all, you're the experts in this space. This is your wheelhouse. Hyperacute resuscitations is EMS, especially 911 EMS. No disrespect to my interfacility colleagues, but this is what you do, and you're the experts and trust that you can do it, and that Chief Nats and Chief Rund and all of us support you doing your job the way you need to do it. This gentleman down there is a cardiac arrest that Station 10 had a couple months ago. He came back to the station with some pizza. VFib arrest, got phenomenal on-scene care by an engine crew and then a medic crew, and was resuscitated after choking after playing pickleball. He came home and ate a watermelon and died, and we brought him back to life, and he's eager to get back on the pickleball court, and that's why you do this. And we'll have more of those in this department. We'll try to celebrate these wins because we have. So thanks to Dr. Barinholtz and the Pikesville Volunteer Fire Department for putting this all together. A couple references here. I'd be remiss to not thank Mark Pinchak, the Assistant Chief of Pittsburgh EMS, for inspiring a lot of this nationwide, honestly. And then Andrew Bolin, Dr. Bolin now at ECU, for his presentation that I told him I was stealing from. He's very well aware. Told him he needs to publish it before someone else scoops him. And then honestly, thank you to you all for all the work you do. I mean, we can't use all the data if you don't generate it, and we can't save lives if you don't do the life saving. I'd like to think my job is important, but at the moment I'm mostly a keyboard warrior, and you guys are the ones doing the work, whereas I try to help guide you from afar, but you guys do the work. So thank you for that. There's my 2 email addresses. I respond to them all too much. I have too many cell phones, but there they are. And then I'll take questions via the chat if you have them, or offline. And then if you have something particularly offensive to say, Dr. Barinholtz will turn the audio off in a couple minutes and we'll go over it. I see that Jay Clements asked about gathering data anywhere else. I haven't personally started gathering any data. At some point, we'll look at this in Baltimore County. Once we build dashboards and stuff like that, I've only recently started talking with our data people here to build some dashboards, and we'll get them going. I don't know that we'll have a crashing patient dashboard. If there is anyone, I can scan quickly from Montgomery County on. Montgomery County, I know, uses First Watch and First Pass. And they actually, Montgomery First Watch calls it a trigger. And that's a kind of funny word because it sounds like they're being triggered. But First Watch alerts them when someone's vital signs are suggestive of a crashing patient. Ben Kaufman, I see that you're here. If you want to chime in and talk about what you do in Montgomery County, I know that you do use technology to try to catch these cases. I think for the purpose of re-education or further education or just awareness, I'll cede the mic to you if you want to unmute and have anything to add.
Yeah, we've been using First Watch for a few years, several triggers. So we're proactively looking for case data of a whole bunch of things. We're looking at cardiac arrests, strokes, STEMIs, but the one that's pertinent to this conversation is called cardiac arrest after EMS arrival. So as soon as the clinicians finish the report and they upload it, First Watch gets that data and that immediately emails the quality management team and myself. So we're all getting a de-identified patient data directly to our inbox, and we're all immediately chatting one another and reading the narrative. So we've got a good handle on the number of these that are happening. Each one of them gets closely scrutinized, and we still see these things happen, much as you described. There's just scenarios where it's not ideal to resuscitate in place, but unfortunately, when we do see movement causing or leading to or associated with cardiac arrest after we get there. So.
Yeah, it's a reality. It's going to happen. The number is never going to be zero, but we want to push the number as close to zero as we can get it. And I've never personally been a part of the Montgomery County QA program. I'm sure it's much like our growing QA program in Baltimore County. The purpose is not for that gotcha moment. The purpose is, make sure that your documentation tells the story, figure out, is there something we can do better? I think, Chief Coffin, that you guys were talking about some systems changes, like you discovered that where you stored your CPAP mask was cumbersome to crew members, to clinicians. And so you guys are looking to change where you store your CPAP mask to make it used more frequently so that you can complete the bundle more quickly. Am I accurately summarizing that?
That's exactly right. A lot of times we go back and look at somebody who was a clear candidate for CPAP and they got moved. We go back and realize that the person or the crew didn't bring CPAP into the patient's side. CPAP was a separate bag, so we are piloting a bag, the airway bag that adds the CPAP equipment to it, and we're hoping that increases the chances that we're going to provide care right at the patient's side. We've pushed a lot of communications out to our people about this. Captain Shipley, our QA officer, has very open and honest conversations with the clinicians when these cases happen, and we're slowly moving the needle. I think we had Dr. Lawner on a podcast talking about, we also called it PARCA, similar to Buffalo, prior to the Maryland adopting the critically unstable patient protocol. So he was very helpful in educating our people. And then we talk about it at Con Ed, so we just try to keep it out in front of people and stay ahead of it. So
thank you for sharing. And you guys, your QA program is to be envied. I'll try to be you as best we can with our own unique challenges and opportunities here.
Oh, stop.
Dr. Nusbaum, great presentation, amazing, great topic, really pulling together. Yeah, I think something that we all struggle with in various ways, and never really had a solid. I personally didn't have a solid framework to even think about it, but super compelling data and incredibly important.
So I guess, Dr. Barinholtz, why don't you cut off the recording now, just